Well, Kathleen, it's 7 o'clock. Do you feel ready to begin?
Yes, I do.
Okay. Well, I'm Dr. David Meyer, and it's my great pleasure to introduce to you Kathleen Bell. And I think most of you know her at this point, but she's done some work that she's going to share with you. And the way this works is she's going to give a presentation. It's about 40 minutes, and then there'll be some time for question and answer period following that. And we're crossing our fingers that we have all the Zoom controls right to prevent any sort of shenanigans. Um, and then shortly after the question and answer period, we're going to take a brief pause, and then the committee is going to convene with her in private, and that will be the end of our public portion. This is also being recorded for asynchronous viewing later. And thank you all for being here. And please welcome Kathleen Bell.
Thank you all so much for coming today. And I'd like to share with you my study on the utility of vocal function exercises as an adjunct therapy for voice disorders in singers with suspected laryngopharyngeal reflux. First of all, I would like to thank my amazing dissertation committee for all their time, effort, and really helpful comments, and especially Dr. Meyer, the chair, and my advisor for his just incredible part of this journey, which has been many years. This is just going to be a brief overview. The presentation will be in 7 parts, and we will have several slides, and we're going to go a little bit fast in the beginning so that we can get to the good stuff of the results and the discussion. So I apologize for that in advance. So let's begin. Why are we talking about reflux? The simple answer is it's highly personal for me. I was diagnosed with reflux 30 years ago, and I had these very strange symptoms of lack of stamina. I thought that there was some kind of problem with my technique, but no matter what I tried, I just couldn't get through more than 30 minutes of singing. So I went to the ENT, and they diagnosed me with both laryngopharyngeal reflux and muscle tension dysphonia. I wasn't sure exactly what that meant. And so, but I followed their advice, and I did the lifestyle changes, the medication changes, but then my vocal symptoms would come and go. And then I started teaching and noticing that the same thing was happening with my students. And then I talked to friends, and it seemed like everybody suffered from reflux. And so it made me question what is going on here. And just like this visual that we have here, my journey was a big learning curve through this. There were many steps to learn about in this process about LPR and how to better help and serve my students. But as with everything with me, it wasn't linear, and there were stops and starts to get up to the top of this, which led me to the vocal function exercises. Thank you to Dr. Kathleen Wilson, who first introduced them to me. So what is LPR? Basically, you probably all know this, but it is when refluxate goes from the stomach up through the esophagus and into the throat. And it is the most common non-lung, non-allergy cause of cough. So if you don't have allergies, it's very likely that you could have at least some reflux. But what is the specific problem is that there are serious health consequences to this, even though it's very normal and can happen up to 50 times a day for GERD. But any kind of reflux going up into the throat could lead to voice disorders such as vocal fold lesions or paresis, or even muscle tension dysphonia like it was with me. But today we're going to talk specifically for singers with suspected LPR symptoms. They're going to be any kind of vocal irritation or edema that leads to some kind of compensatory singing behavior that could also lead to voice disorders. And what is causing this problem for singers in particular? as opposed to the general population, is that the medical interventions are not quite adequate for our needs as singers, because we need our vocal folds to be pristine. We need to have um, as many choices as possible in our vocal palette, but we can't if we're having some kind of irritation, swelling, or pain even. So how can we as voice teachers, I am not a speech language pathologist, I am not a medical doctor, but how can I help my students and how can I help myself? Well, we can look to the speech language pathology world and investigate the types of therapeutic techniques that they use. And some of them are very easily incorporated by voice teachers. And these include any kind of semi-included vocal tract exercises, such as straw phonation, or in the case of this study, the vocal function exercises. And then they can become something that you add to what you're already doing medically. You're listening to your doctor. This is not a cure for reflux. This is just to deal with the symptoms vocally that you're having. But what happens if we don't do this? We know that LPR is increasing at incredible proportions. Some statistics say up to 400% increase since the 1970s. And there are many reasons for this that are not within the scope of this presentation. If you have these symptoms, then you're going to employ some compensatory behaviors in order to still be able to sing in the way that you want to, and still be able to make those sounds, those wonderful, beautiful sounds that you want to make, or maybe those dramatic sounds that you want to make. So in order to do that, you're going to maybe press like I was. You're probably going to be coughing or clearing your throat all the time, and that leads to vocal damage, and eventually to quality of life will suffer because of this. So again, why should we care? Because it limits our choices. It can be career ending. Many people I've talked to, they said, I just can't deal with the reflux. I can't deal with today not knowing what my voice is going to be like because of what I ate. And then on a health perspective, you in the short term can get reflux laryngitis so that you can't speak and you can't sing. But then more scary is that you could eventually develop Barrett's esophagus, which is precancer, or laryngeal cancer or esophageal cancer if this is not addressed. So this is life or death. So for this study, I decided to look at 3 questions. I took the vocal function exercises and wanted to see how would they affect the voice symptoms of singers. Secondly, would the singers be able to perceive a difference in their function? And thirdly, did the measures that I chose, that I did choose, were they the right ones to evaluate the voice and these changes? So let's see what happens. First, we look to the literature review. For those of you who know me, I kind of think of myself as a vocal detective. I'm trying to figure out what is going on with my students' voices. Why, when we ask them to do a certain passage, sing a certain line, it's not going the way that they want it to, the way that I want it to. How am I better able to serve their needs? And there's a lot of talk right now about evidence-based, teaching, but how do we find that evidence? So we need to look into the writings of voice scientists. We need to look into medicine. We need to read the journals about voice therapy. We're going beyond what is artistry, but moving into a broader perspective of just the entire health of the person, because we're not teaching a voice box, we are teaching a whole human. And so when we're doing that, if we're paying attention, if we're really present in the lessons, we can notice that there's something going on with my student or with myself that is so minute that maybe the average person wouldn't notice, but we hear it because we're listening to them every week, sometimes more than once a week. And we can maybe let them know that there might be something going on beyond technique. I think it's really important for us as teachers to be aware of the possible reasons why a person isn't able to produce the sounds that they want. It's not that they don't want to, it's not that they don't practice, but what if there's an underlying reason in their vocal health? And what if that reason is reflux? So you need to know about voice disorders. We, we are in an age of information, but the most important thing is to realize that if it's persistent, and if it's not consistent with their age, the gender of what I need or what they need as a vocalist, then it could actually be a voice disorder. But it's so complex. There are so many factors to look at. There's signs which would be maybe laryngeal signs or acoustic signs. They could run out of breath easily. That can be a sign of dysfunction, not a lack of practice. And so then our symptoms might be how I feel, how, as a singer, what am I experiencing in my body? We want to know there's many causes for what could be going on with your voice. And there's then on top of that, each voice disorder does not affect each person the same way or to the same degree. And then compound that with that there are so many other disorders that might join in with LPR. You might have muscle tension dysphonia like I did. You might have vocal paresis. You might actually have vocal nodules. So how can we discern what is going on? In an ideal world, you'll have a whole team of people there to help you and help your students. We'll have the medical specialists that will do a visual perceptual evaluation. We'll have the speech language pathologists do an audio perceptual evaluation. And it has to do with listening to the sound. Is there roughness? Is there excess breathiness? Is it weak? Do I sense strain? Then very, very important, what does the patient feel? Because it may sound okay to you, but they're like, this is not my normal. This is not what I'm feeling. And they know their voice really well, so listen to them. Then if we're so blessed to have a voice lab like we do at Shenandoah, you could do acoustic and aerodynamic measures, and you can spectral analysis. I've just listed the ones that I was involved with in this study, and you could do how little pressure does it take in order for the vocal folds to collide? That's collision threshold pressure. So we're going to look at the voice in many different ways, and then probably my favorite, voice range profile, and not just your run-of-the-mill voice range profile. We're going to look at their ability to sing all the frequencies and how intense can they make each sound. So basically what that means is sing it as softly and as loudly on every pitch in their entire range. And then not only can we get a map of their voice, but we can also see within that a spectral analysis. So this very vivid picture, thank you, Dr. Carroll, is what your vocal folds might look like if you have reflux. And as you notice, there is redness in the arytenoid area. In the posterior area, we see some irritation, but otherwise, the vocal folds look pretty healthy. They're pretty white. I'm not a doctor, so I may be saying something crazy, but I don't see any lesions. I don't see any extra bumps. I see a little excess mucus maybe, but it's just more red and angry. And so that's not going to feel so great. So some key things to remember about LPR. There is no cure. So we're going to have to manage it, and it probably will be chronic. And if you are like me, who is recently diagnosed with a hiatal hernia, this is why it will be with my life. Throughout my life, this is what I will experience. So I can manage my condition. I can do the things that we're going to talk about in a little bit that will make it a little bit better. And it's also really important to remember that it's not always acid, but it's acid that activates pepsin and other gastric contents that then destroys the cell matrix of the vocal mucosa. And this is really important because that's where phonation happens. It's all about the mucosa. And so any edema and irritation is going to be a huge effect for voice professionals. I love this image because that's how I felt. I I was like, why? I'm always asking why. Why can't I do what I want to do? Why is my registered transition so crappy? Why am I getting tired? And so we feel like screaming into the darkness, and these are the most common symptoms associated with LPR, but also, as you notice, this could be allergies too. This could be any number of things, but they definitely are present, and they were present with me in different ways. So when we design a treatment, we have 4 goals according to Saddleoff. It's really important that they want to first heal the mucosal injury, whatever that may be. And that is not in the realm of the voice teacher. That is all up to the ENT and the speech language pathologist, the medical team. And then if there are any complications, then they need to manage that. So whether it's paresis, MTD, whatever, you're going to need to look at that. The goal, though, is to eliminate the symptoms. And then once they're eliminated, we want status quo. We want to be able to do that, be able to sing like we want to. We need a way to do that. So very quick, I will be making available a handout which will have this in more detail, but there's going to be diet and lifestyle, medical, surgical, or therapeutic ways of treating this. So just if you want to know quick and dirty, it's going to be small meals is the one that is the most probably the most helpful. And then medical treatment, anywhere from antacids to alginates to PPIs. You might need surgery, especially if you have a hiatal hernia, but then therapy is going to help you with the voice symptoms. So if we go into therapy, again, I said that one of the main programs that they use is the vocal function exercises. And so it's a direct physiologic program. So what it does is it helps to retrain the muscles to behave in the way that we want them to. It's in 4 parts, and it has a semi-occluded vocal tract posture to it, which I will demonstrate later. What is wonderful about this program, there's like 30 studies right now that have been peer-reviewed studies, and they have shown that it benefits many different populations. It helps to balance all the subsystems, whether it be neurological or respiration, helps to balance your phonation. And so it leads to efficacy and to help you not be hyperfunctional in your vocal technique. So with all that evidence, we're looking to see if this would work with singers that have suspected LPR. Now we get to the good stuff, to the study. So in 2018, the IRB was approved by Shenandoah University. It is a quasi-experimental outcome study. So it had pre and post measures, but quasi-experimental because I did have a treatment and a control group, but it was not double-blinded. The study inclusion was that they needed to be symptomatic and they needed to have a medical diagnosis of either hiatal hernia, LPR, or GERD. Now, I'm going to say it right now. I did not have the copies of everyone's medical report. It was self-reported. I did get a couple of letters from the ENTs that said, yes, they have GERD and they are taking this, but we did not have a laryngologist on site scoping them at the beginning of the study. They just needed a history of reflux. My thinking with that is like me, even after medically treated, I still had voice symptoms 5-10 years later. So, as I said, it was a convenient sample in the area where we looked at professional and avocational singers, and the final total was 17. We started with 20, but 3 of the controls dropped out. There were 2 groups. They met with me once a week for 6 weeks, and first I gave them anti-reflux education, and then the control group had just normal 30-minute voice lessons with warm-ups and repertoire preparation. The treatment group What was added was that they were supposed to practice the vocal function exercises at home. And then we did pre and post measures. So the measures that were taken, we did objective measures that looked at 4 different voice symptoms. The first symptom was hoarseness, and I analyzed that with capsular peak prominence, with the analysis of dysphonia voice program. And what they had to do was sustain an ah at a comfortable pitch and volume for about 5 seconds. And I captured that. They held the microphone about 15 centimeters, and we had a bar like so that they could keep that distance steady. And then we recorded that, and then the program gives them an analysis of their capsular peak prominence, which has been shown to have efficacy with rating hoarseness or dysphonia. The second measurement, the next 2 measurements were the voice range and voice breaks, and I captured that with the voice profiler system by Alphaton Medical Systems. And so what they needed to do was the VRP protocol, which is that sustained ah from their entire range. So they had to sing as softly and then as loudly on every single pitch in their range, and we went up in half steps. And then the program was used to analyze both the frequency and intensity range to make a map of their voice, but it also was able to look at the spectral metrics and see where they relied more on their second harmonic as opposed to their first harmonic, and where we could infer where they were going from mechanism 1 to mechanism 2, or commonly called chest voice and head voice. Now, the last symptom that we looked at objectively was the inability to sing softly. And what I did was I analyzed that in 2 different ways. First, I used the voice efficiency with EGG protocol to gather CTP, so collision threshold pressure, and that's with KBELL system. And what they had to do was sing pa, 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 and gradually get softer. And then there's a process of looking at the different peaks, use the EGG to measure when the vocal folds were in contact, and then when the line flattened out, then you could see where the vocal folds were no longer in contact. So there was a process to then extract the data from that. And it's a little complicated, and I don't really have time to go into detail, but you can ask me later, and then I can show you some fun pictures that makes it easier to explain. And then the second way that we looked at inability to sing softly was to use the lower contour of the voice range profile that I had generated with the voice profiler system. Okay, now we need to know how the subjects perceived their symptoms. So we analyzed that with 5 different Likert scale measures. So the reflux symptom index, of course, because we wanted to see if they were experiencing symptoms of reflux. And then voice handicap and singing voice handicap are the 2 most common used in medical offices. The adapted board was used to measure their experience of effort when they did the VRP task. And then lastly, a singer-specific questionnaire that I developed with Dr. Sadaloff that has to do with these symptoms that are directly related to suspected LPR. So what was the treatment? So for those of you who are not familiar with the vocal function exercises, you have 4 different exercises. The first one is just a maximum phonation time on the E vowel as softly as you can. And so that's kind of your warm up. And then you would do the null buzz, which sounds like this, but you would expand by taking it from a low pitch up as high as you could. So you would try to go up and try not to have any voice breaks while you were going up, and then contract. You go down. And then the fourth part is the part that takes the longest. So you would sustain with the buzz sound. Again, maximum phonation time, incorporating the buzz. For women, middle C, so C4, and then repeat it on D4, E4, F4, and G4. So 5 different pitches. The basses would do the same thing an octave below, and then the tenors would start on F3 and then go up and repeat the process on the 5 different pitches. So they were asked to, this takes maybe 10 minutes, and then they were asked to do that twice a day for 6 weeks. And as a compliance, they needed to journal by writing in their times, their maximum phonation times of both the first exercise and the fourth exercise. So it was this huge chart they filled out, and they did it. All right, so then we have to, once we get all the data after 6 weeks, then it was the fun to analyze it with IBM SPSS version 27. We did the normal descriptive and bivariate analysis, one-way ANOVA, correlations to see how, if there is any effect of age or gender or what style that they sang. And then the last one is a non-parametric measure, and we chose that because it was a very abnormal distribution of data, because you had multiple measures and also different ages and different styles. I mean, it makes it difficult. You can't really generalize. So, and also the small sample size, as you see, it was only 17. There were 10 treatment and 7 control. And then we also chose that because of the Likert scale. So it's in ordinal data. So it seemed more appropriate to use non-parametric analysis to get a little bit more deep into what was going on. So here are the results. First of all, we have our participant demographic. And as you can see, it's relatively homogeneous. The age range was more or less the same, with a mean in treatment of 38.8, but in the control 38.4, more or less the same. Their BMI, more or less the same. There was just a little bit more contemporary singers than classical singers, but again, pretty similar on the surface. So how did it go? So what we found out was that with the CPP task, it was not found to be significant at the 95% level. However, all the other measures, objective measures, were, and pretty exciting register shift and total VRP were highly significant. So like 99% chance that it's 99% that it wasn't chance that these changes would have occurred, which is pretty amazing, actually. Now, the perceptual measures, all except for the adapted Borg, were also significant to a little bit lesser degree, except for we do see quite significant the singer-specific questionnaire. And also within the questionnaire, there are 6 questions. I listed the 4 that were significant. So significant changes in their perception of their voice change, their perception of their warm-up time, their perception of their pitch range, and their perception of being able to sing softly. All right. I know this is a busy slide, but it's one of my favorites. And this is the non-parametric analysis that I had talked to you about. So what we have here is each node is a different measure. Each chord is the connection between measures. The thickness of the chord is the strength of the measure. And you may ask, what is that number? Well, that is the ranking of that strength. And how is it ranked? It's a combination of how many connections it has and then how strong those connections are. And so why do we care? Why is this important? Well, it's really interesting. Their ability to sing softly was very strongly related to, or their or you could say it the other way, their perception of their speaking voice was very related in the pre-measure to their ability to sing softly, and their also to their degree of hoarseness. So interesting how hoarse the voice quality was related to how low they could sing. Interesting. So then we also have some very stronger correlation between the CTP measure and their size, BMI. We see a strong between those who had stronger reflux symptoms were also tended to be the females. So that was a strong correlation. But what's also interesting, and why I tortured you by putting them both on the same slide, is that it changed in post. So it would seem that the vocal function exercises, the treatment, somehow changed the relationship between all of these measures. And so there's still a pretty strong relationship between a dysphonic sounding voice and their ability to sing softly. But now those who are a little bit bigger feel a little bit worse about their voice. So I don't know. It's just interesting that we see this. What is also interesting to see is when you look at sorry, that's my dog. I think she has reflux. So if you look at the number, the ranking, the most significant or the highest ranked measures were all to do with the VRP, which is interesting. So basically our range was related to almost every other measure. And the same thing happened in the post measures, but even higher, even a stronger ranking, 15.8 as opposed to 14.7. So that's pretty significant when you're dealing with only 10 participants. That's a pretty significant change, which is interesting. So let's discuss this. What does this mean? What can we glean from this? And I also want to look at each more individually, because as we know in voice, as Dr. Meyer likes to say, every lesson is an N of one. It's very important to look at the individual, and one size does not fit all. So let's look at the individuals. Even though CPP was not significant in the aggregate, 50% of the treatment participants did increase their score. And in fact, the 80-year-old female had a 65.6% increase in her CPP. And this is the graph that displays that. This is the regression line. The goal is for this peak to be as high as possible. As you see, it's very weak. But it was much higher in the post measure. It's still within a disordered voice. It's still below the normal threshold, but it's better. Then we also look here at the subsequent harmonics, and they should be more regular peaks. They are a little bit more regular in post. Okay, so now if we look at upper range, we notice some interesting trends. We have here that the men actually experience greater changes, as much as 66.7%. So from 600 hertz to 1,000 hertz. And then there was one that did not increase. And unfortunately, P6 had a very severe allergy attack right before the post-collection measures. So I could have left him out as an outlier, but I think it's important to look at this anyway, because probably his real problem was allergies and not reflux, and that needs to be addressed. Now, this is probably one of my favorite slides too. As you can see here, we have a tremendous change for this 24-year-old male professional contemporary singer who actually had a history of paresis. If you look here at the graph, the background in blue is the post measure, The colored measure is the pre-measure. So his voice range profile completely grew. It's interesting, the shape stayed the same, but his most of his improvement was here, gaining over an octave, which is pretty significant. And I talked to a friend of mine that's a speech language pathologist, and she said with paresis, they often cannot sing higher. And so I don't know if his problem was really reflux or if I actually helped him resolve his issue with paresis. But we were happy regardless. So we have here this incredible change. And as you see on the left, in aggregate, it was 81.7% increase, with individuals anywhere from 9 to 44% increase in their total VRP, and also in their upper range, a tremendous improvement overall. With the men, as I said before, having greater improvement over the females, which makes sense. If you consider falsetto, that is. All right, so here what we have is the register transitions. And so this correlated with voice breaks. So when you're trying to go from chest voice to head voice, sometimes there is a difficulty with transitioning between the two. And so what I did, and I'll show you on the next slide how I got these numbers, is I took the sound pressure level from the pre and then compared it to the post at a particular point where there was a dip in their contour. And let me show that to you. If you just see here, these are the percentages of change. As you see, again, there is a difference between males and females, with females having more change. So here's a 69-year-old female choral singer, and I have pointed here with the arrow where there is a tremendous loss of energy. And it looks like it's right around C#4, D4. And so you see here also the color. The color is significant. So in this spectral metric, it is displaying the balance between the second harmonic over the first harmonic are fundamental. And so if there was a stronger reliance on the second harmonic, the color would be red. If it is less so, then it would be green. So, and Dr. Pompon is here, and so hopefully I explained this correctly, is what we can infer is that if they are relying more on the second harmonic, then they are in M1, mechanism 1, or chest voice. As you see here with this person, this is a very weak sound. They appear to have very little reliance on H2. And as they go higher, there's this dip, and actually she called it the Grand Canyon. And it is pretty dramatic. Then in the post measures, look at the shape. It's completely different. It is really smoothed out. She actually is able to rely more on H2, and we can infer perhaps that was her belting. She actually was able to use some chest voice, which is kind of exciting. She really thought that her voice was gone. And if we see here, much more functioning, and then was able to find some whistle tones. So the voice was stronger, had more energy. She obviously didn't have problems singing softly, but where she saw most improvement was in the upper contour, or the ability to sing louder. And also there was a change in how she sang louder. What we have here is the overlay of the two. So again, the blue is the post and the colored portion is the pre. And if you see here, I took her numbers from these two spots. So pre-SBL and post-SBL. It's pretty phenomenal change. Her Grand Canyon was no longer that grand. Our second example is a 35-year-old female contemporary singer. And if you see here, she also had a break. Her strategy was very different. I've taken off the H2, H1, but it's the same type of metric. If you see here, she was able to rely more on H2, inferring chest voice, and then a drastic change right about high C, C5. So if we look here, we can see this drastic shift in energy and also a shift in harmonic spectrum. She's no longer really relying on H2, but it takes her a while to recover and to be able to get volume relying on a different spectral metric. As you see here, there's some difficulty, but in the post, it's completely smoothed out. And so she still sings predominantly in chest voice, but actually is even more reliant on H2. And then when she gets close to that dreaded C, she is able to now adjust by relying less and less on H2 and slowly changing the ratio to green. So very slowly going from creating a stronger volume with more of a mix than just a drastic chest voice to head voice. And this is the overlay to show the difference. All right. Now, our inability to sing softly, as I said, was evaluated in two different ways with the CTP and also the phonation threshold or lower contour of the VRP. And so, as you see, all of them, except for one, P16, was able to sing softer. But if you look at the numbers, her pre-CTP was rather low, and I suspect it was probably a weak sound. So it's hard to know, was this better or worse for her, actually? I'm not sure. If you look at the sound pressure level, again, 90% of them had a decrease in phonation threshold, so better control of being able to sing softly in the upper range, except for now this person, P6, was higher. What is interesting to note, different task, same person that had increase in CTP, over here was able to sing something more softly in the upper range. And so you may ask, why did I choose the 75% point of the range? And I'm going to illustrate with the VRP. So this is the entire voice range. However, not all of it is useful in singing. I think it's Dr. Nair called it the performance range. So we have a functional range and we have more of a performance range. So decided to look at the 75th percentile point to see that's going to be the more usable range, and it would be more important whether or not you can sing softly at that part of your range. As you see also here, looking at the lower contour, is that the phonation threshold expanded all over. Actually, his entire voice range expanded, but it's so interesting to look at. The shape is still the same. It's the same voice. However, and if I look in here, it looks like similar strategies, but just now he's able to sing falsetto and also sing softer at that high note of, looks right around between B and C. This is our female singer again. She had tremendous ability to control the soft singing now in this part of her range. She didn't gain a lot of high notes. However, she was able to have more dynamic control with her voice post-treatment. So what did we find out perceptually? So first of all, the treatment group was highly symptomatic. Every single common metric was over the normal threshold, but this was also highly variable. So that is interesting to note. Within their self-perception, their voice quality, also 80% of them said that it improved. And and 70% of them said that longer warm-up time also improved. So what were some of the correlations? Because as we talked about before, voice disorders and voice symptoms are very complex. So let's see if we can glean some kind of correlations. We found with gender that the female participants experience more distress over not being able to sing the way that they wanted to. And we also noticed that with the male participants that they had increase in upper range. Also, voice range correlated, so all perceptual measures correlated with their upper range, meaning that how they felt about their voice was directly related by how high they could sing. Seems like singers. Okay, also in my study, the reflux symptom index was not really sensitive for this population. The first question deals with hoarseness, and it only correlated with CPP 41% of the time, meaning that when they thought that they were less hoarse, it did not always show on the CPP and vice versa. The two measures did not move in the same direction. With this group, age was actually not a factor. And effort and fatigue, there are several questions within the perceptual measures, and they only correlated half of the time. So I don't know if it's maybe if it's a language issue of what effort is or what fatigue is, or it could be, you ask someone a question 4 different ways and you get 4 different types of answers, even though it's the same subject. So I'm not sure exactly what that meant. As far as style, this was really interesting. And I think it was demonstrated in the VRPs that you saw that the register shift for contemporary singers was higher than the classical singers. It was not at typical E4, F4, but it was between B4 and D5. And it didn't matter what gender they were. Both the male contemporary singers and the female contemporary singers shifted on the same pitches, which is fascinating. And so in conclusion, we made it up to the top of the mountain. We have made it to the end of the dissertation presentation. Just to recap some things. LPR signs and symptoms, they're so individual. And so I think even though the N was small, it's still important to look at, because if we look at individuals and how they react to LPR and what kinds of symptoms, it's always important and to just document it, and maybe eventually we get enough people, we'll be able to say something more. The treatment effects, at least one metric improved in every single participant, even our allergy sufferer. But the most improvement was in their ability to sing softly, their entire range, and their register shift. That was the most improvement that they had with the treatment effects. We also saw within quality life that their perceptions, they were significant. They did show improvement, but it was to a lesser extent than the objective measures. So I don't know if it's an issue of us as singers always wanting more, or I'm not sure. We'll see. And there was a moderate correlation with the objective measures. So even though they had, except for upper range, that agreed with how they felt about their voice, but not necessarily all the other measures. And so I had those 3 questions. How would it affect the participants objectively, perceptually? And the third question had to deal with, were these the right measures to actually take, and was it helpful? I think CPP would be helpful, but there was a mistake in how I did it. I did give them a pitch reference from pre and post measures, but I did not give them a volume reference. And so CPP is directly affected by the strength of the signal. So if their goal in every other activity was to sing as softly as possible, so they might have misunderstood that one, they should also sing as softly as possible. So that could be a factor. I can't really say for sure, but that's my guess. CTP seemed to be effective, but it's pretty complicated to do, and there's a lot of computations. And I don't know if the posture is that related to singing, actually. So I think it was an interesting exercise for me to do, and I enjoyed learning about it, but I don't know how much I would use that in research. Now, the voice profiler, on the other hand, I feel was the most robust measure. I could evaluate so many different spectral metrics. There are actually 10 to the 6th power of ways to look at the voice, and we looked at what, 3? So it would be kind of amazing to look at singer's format, to look at other things as well, and to just go real deep dive into those voice range profiles and just see more of the functioning of the voice. I have talked to Dr. Prabhan, and he has some exciting news that be able to incorporate EGG in the future, which would then make it even more robust, so that we're not just inferring that they switched from M1 to M2 by their harmonic strategy, but we have a little bit more robust inkling that it's true. I think that the perceptual measures are still not specific enough for singers, with the exception of the singer-specific questionnaire. Leshian et al. Is also developing one that is a reflux singer specific questionnaire, which I think is very exciting. I think we need to get more nuanced about how we ask questions of singers. I think now that more and more singers are getting, and voice teachers are getting involved in research, that we can add to that conversation. So limitations, very clearly, it's too small to make any kind of generalization, but it's exploratory, and it does point to maybe investigating more of those things that I talked about. And then the big elephant in the room, we don't know if LPR was really the cause of their voice symptoms. We don't know. I don't know if you ever really know, but you really don't know with my group, because even though they had a diagnosis of GERD or LPR, it's hard to say because they were not scoped on site. Like I said, I suspect that P6, his real problem is allergies. Maybe there is some undiagnosed phonotrauma that I was, quote, treating or as an adjunct. And were some of the changes for the older population just because they had presbyphonia or bowed vocal folds? Don't know. A couple of them did have scopes, and they were diagnosed with MTD, but as far as I know, no vocal inefficiency. So where we'd like to go next, like I said, it would be very exciting to investigate further where musical theater people shift between M1 and M2. And also, I would like to really explore with the mature singers how we can use the vocal function exercises to increase their dynamic control and smoother transitions. I feel like it was, even though the goal was to sing softly, one of the benefits of the vocal function exercises, according to Dr. Stempel, is that the 4th exercise is a voice building exercise. And so even though you're singing softly, you are actually changing the way that the muscle can react, and you're strengthening it. And so it would be really exciting to investigate that further with older population. And also would love to, in the future, have a laryngologist and the SLP on the team on the research, so that we could also simultaneously, when taking the VRP, have audio perceptual measures from the licensed SLP. We could also have the proper laryngoscopy and stroboscopy for every single person, pre and post. And as I said before, the voice profiler with EGG to examine more voice breaks / register transitions. It would be exciting to include longitudinal changes. So meeting up with the participants again a year later, 2 years later, and how are they doing? Are they still incorporating the buzz? I did talk to a couple of them, and they are, which is pretty cool, but not within the scope of the study. And also using qualitative analysis. So some structured interviews would be very interesting because it is so highly individualized in voice. These are just some of the references. If you are so brave to read the dissertation, there are over 265 citations. So, but this is what was used on this particular PowerPoint presentation. I thank all these authors, and I thank the village that has been here with me on my vocal journey. Uh, these faces here are have affected my life as a researcher, as a teacher, as a colleague in incredible ways. And I thank you all. I thank you, Dr. Meyer, Dr. Green, Dr. Abraham, Dr. Carroll. I thank the Voice Foundation, PAVA, Dr. Tisa, and National Center for Voice and Speech. I could go on and on and on of all my thank yous. Thank you so much for paying attention. Sorry I went so fast. And this is the end. Thank you.
Thank you, Kathleen. Sorry that we live in the age of the quiet Zoom screen right now. We're running a little bit late on time for the committee, but we have a few minutes for questions. If anyone has any questions, please just unmute yourself and ask.
Oh, they can't unmute themselves.
Oh, well then can they raise their hands and one of the hosts can unmute them?
Yeah.
The quiet Zoom screen. I see Professor Lucy Hoyt.
Will you let her in?
I asked her to unmute. We'll see if it works.
I have. So I just wanted to know if you do a study of older singers in your future, can you do it through Zoom? Because I would qualify.
Ooh, you know.
And I thought you might find if there's a way to do these tests, it might be easier to get a population of the type of singers trained, but older. Might be fun.
That would be fun. I think, I mean, definitely we could do the lessons for Zoom. We've been doing that over a year.
Right.
But that actually could be a question for Dr. Pabon. Like, is there a way? Because I think for the voice range profile and the profiler, if there is a way for it to be in an app or more mass produced, hint, 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 then we could totally do that. We obviously can do perceptual measures, and I would like can explore that way, and for sure structured interviews. But as far as objective measures, it would be either that or me doing a lot of traveling.
Okay, just a thought. Just a thought for the future.
Yeah.
I saw that Dr. Pabon unmuted, and I see Dr. Van Leer.
Oh, I have the power to unmute.
Go ahead, Dr. Van Leer. We can hear you.
Yeah, so that was great. Yay. So maybe no one has reflux, but everyone gets diagnosed with it. I actually don't, they say about restaurants that if you set your foot over the threshold, you need to add 200 or 300 calories to your day, like without even. And I think that when you set your foot over the threshold of a voice clinic, you will get a reflux diagnosis. Dr. Carroll may disagree, but even if it's a physiological fluctuation and kind of variation that we all have to deal with, then there's still wonderful findings, right? People who have these kinds of issues, who complain of these kind of issues that we don't know what the underlying etiology really truly is, are they benefit from this exercise set.
So yeah, I think yes. I think yes. Maybe no one has. I don't know. Because I have reflux and I know I do. I have a hiatal hernia. I have voice symptoms related. I can directly feel a difference when I've had an episode. Um, so I think for whether or not the voice symptoms are related to the reflux, if you take out, if I really behave and I really do, if I sing with balanced phonation, I work on my posture, I do all the things, and then I have a reflux moment episode, and then my voice goes to crap, and but then I can reset. I think that's the takeaway is because I do this all day. I can't tell you when I was practicing yesterday and I was refluxing like crazy because I was stressed out. Then I just went, okay. And it was so funny because I was doing the like because with PowerPoint you can get a coach to like listen to you and they'll tell you stop going so every time I did the buzz, it thought I was going it was very funny. But because I was freaking out, I was a million times. But it resets my voice. So I guess, yeah. I mean, for me, I know it's related to reflux because I feel it. It's like burning symptom.
And then there's a question also about whether you would be appropriating the exercises from speech pathology, because I'm not sure if they actually originated there, right? With this F. Bertram Brees dude
Yeah,
from Syracuse. I don't know what he was. I think he was a music professor.
might be. And I don't know. It was funny when I went to a talk with Dr. Stemple, he said, people are always asking him, how did you develop these exercises? And he's like, I made them up. I gleaned from other people. And he's like, I thought this is a good idea, and then now we're doing a million studies of it, and they're like, how did you come up with it should be these 5 notes? And he's like, it seemed like a good idea at the time, and for me, when I look at this, I think, well, it's the middle of the voice. And if there is a semi-occluded vocal tract posture, then it's going to help, you know, square out the vocal folds. It's going to help us be more efficient. So it's going to be helpful. And if I can do that in the middle voice, what's amazing is that then that has repercussions in the whole range. That's what I found fascinating. I was like,
I loved it. I'll be quiet now.
I'll make one comment since my name got brought up by Dr. Evil. I love your name on your on your Zoom screen. The reality in the ENT world, and I am a a subspecialty laryngologist. I look at vocal cords all day. I don't see ears or noses or and I claim idiocy when people ask what's wrong with their ears now. So, but my point is, I think we're trying to get away from giving everybody an LPR diagnosis when they have a voice disorder. But the big but, and this is what Kathleen did a great job in, is acknowledging, that there can be other things going on. And some of the research that I'm doing now with colleagues all over the world is, people can have LPR that may have led to phonotrauma, may have led to some of the inflammation that then led to a voice disorder. So you can't, it's like looking at a larynx and just treating a voice problem without thinking about swallowing an airway. You shouldn't and can't do it. It's really hard. So kudos to you, hats off. I mean, I think it's hard to admit, when you get so deep into a project like this, that there could be something else you're treating. But we know speech pathologists help our reflux only patients and have for decades, because they probably had something else that was stirring in there, but it's all intermingled. So that's my 2 cents.
We've got time for maybe 1 or 2 more questions. Does anyone else have a question for Kathleen? Raise your hands if you need to be unmuted, and one of our co-hosts can unmute you. Last chance. All right, well, ladies and gentlemen, would you please do the clapping quiet Zoom screen, and Kathleen will adjourn for now, and we'll reconvene with the committee at that separate link.